Good afternoon, everybody. Welcome to our Coffee Talk series. My name or this these are brought to you by the Active Girls Healthy Women Initiative. My name is Hannah Hoke, and I am an executive board member of the initiative and serve on the research subcommittee. This Coffee Talk series is part of the Active Girls Healthy Women Initiative. The vision of our initiative is to empower girls and women to lead healthy lifestyles. We aim to achieve this vision through our mission to advance girls and women's physical activity and health through research and outreach programming. The primary goal for our coffee talks are to disseminate evidence-based strategies and or information to advance girls and women's physical activity and health. Twice a semester, we hear from an expert in an area that is relevant to our mission, vision, research, programming, or our community partners. After their presentation, we will engage in question and answer session and discussion. Strongly encourage you to participate. If you want to leave your questions in the chat, I will happily read those off for you. At this time, I would like to introduce our speaker, Dr. Wittstein. Dr. Wittstein is an associate professor of orthopedic surgery at Duke University Medical Center. She is the medical director of the Duke Orthopedic Surgery Outpatient Clinic and the residency site director at Duke Raleigh Hospital. She completed her residency and fellowship training from Duke University. Her most recent honors and awards include being selected as a member of the Milken Institute Women's Health Network and as president of the Forum Women in Sports Medicine. Her research areas include shoulder, elbow, and knee outcomes in both pediatric and adult populations and bone health. Today, she'll be talking to us about optimizing bone health for girls and women across the lifespan. And Dr. Wittstein, the Zoom room is all yours.
Hey, you can hear me okay? Okay. So this is a broad topic that Dr. Ireland asked me to talk about, so I like to call it bone health in girls and women throughout the health span because, one of the things we know about women is that women do tend to have a longer lifespan, but sometimes not a longer health span necessarily than men, and a lot of that is related to actually musculoskeletal health as we age. So we'll talk about that later, but. Just some disclosures. Probably the one that's most relevant to this talk is that I am the author of the Complete Bone and Joint Health Plan, which is a book for people about bone and joint health, but specifically lay people, not really directed at physicians or people in the medical community, but just helpful to lay people. As an outline, what we'll kind of cover today is bone density, sort of, what does that mean and when does it peak? What is osteopenia? What is osteoporosis? What causes osteoporosis? And how do we optimize bone health at every phase of life, from being like a tween or a teen to someone in their 20s, 30s, 40s, 50s, and beyond. And we'll talk a lot about, sort of the kind of second half of our life where we have kind of a really significant increased risk for osteoporosis as we age in the postmenopausal phase of life. So when you think about bone density, it's sort of one measure of how strong our bones are. Our bones are kind of they have a thick outer lining and then an inner lining that's can have a certain amount of density or of structure. And as we age, the bones get like thinner, and that's what osteoporosis is. But a lot of people don't realize that how dense our bones are, how much bone mass we accumulate really peaks at age 30. And that is relevant to people under the age of 30. You might think, well, I'm just building bone mass up until the age of 30. But when you're under the age of 30, there are risks for having diminished bone mass that could affect your peak bone mass. Something called relative energy deficiency in sport, for instance, can diminish how much bone you build and form by that age that we typically peak at, and we'll talk about that. But in general, most people gain bone mass and bone density up until the age of 30, and then it gradually declines like 1% per year until women hit menopause, and that is, on average at age 51 or 52, and then bone density declines more quickly at a rate of about 2% per year in the absence of hormone therapy. So, worldwide, 200 million women have osteoporosis, and of significance is, women sustain about 75% of osteoporosis-related hip fractures because of this increased, propensity for this problem. And then what effect does that have? We know that, there's a mortality of roughly 1/3, 1 or 2 years after a hip fracture. So, and we know the hip fractures affect independence and ability to ambulate without assistive devices. So these are things that we would all like to avoid as we get older. But if you look at the big picture, actually, we kind of set ourselves up for success by building peak bone mass up to age 30. How do we measure bone density? There's an imaging study called a DEXA scan, which is dual energy X-ray absorptometry. And most commonly this measures bone density at the hip and the spine. And your bone density is then compared to an individual's density you get compared to standardized results from healthy individuals, roughly age 30. And there's something called a T-score, and if your T-score means you're like 1 to 2.5 standard deviations below the mean of a healthy individual at age 30, that means you have osteopenia, and if it's worse than -2.5, you have osteoporosis. If you get a bone density scan when you're younger, you're going to look more at something called a Z-score, where you're compared to people your own age, not compared to younger controls. But so, what causes osteoporosis or thinning of the bones as we age? Obviously, age is one of those factors, especially for women. For men, we don't see sort of age-related decline until later years, maybe after age 70. Women are more prone to this than men. If you have a family history of osteoporosis, that can make you more prone to it. White or Caucasian and Asian people have higher risk of osteoporosis. And then there are some modifiable risk factors like your dietary factors like calcium and vitamin D intake. Do you live a sedentary lifestyle? I'm going to go through some studies that show how the benefits of exercise, strength training, and impact affect your bone density at all stages of life. Smoking, nicotine exposure is bad for bone health. Excessive alcohol consumption can also be associated with reduced bone density. And then certain medications, like if you're on corticosteroids all the time, like people who have to chronically be on this for, asthma issues or things like that, or rheumatoid conditions. Um, Medications for heartburn and reflux can reduce your calcium absorption. Those are proton pump inhibitors. Being on those chronically can affect bone density. And then other conditions like rheumatoid arthritis, poorly managed thyroid conditions, like chronically hyperthyroid condition can be an issue. Eating disorders resulting in severe energy restriction and then energy deficiency leading to losing a menstrual cycle can cause bone loss. And then other risk factors, there's some people that just go through early menopause before the age of 45. Low testosterone levels in men have been associated with osteoporosis, and then any history of a fracture, especially if it's a low energy fracture, is a risk that you're developing osteoporosis. So, like I was saying earlier, I don't want people to think of bone health and poor bone health, like osteoporosis, as being just something to think about later on in life. I want to kind of go through the various phases. So, premenarchal, so say, younger, tweens, I like to call them, girls who haven't started menstruating yet. And then you have the sort of a postmenarchal phase. So you've started menstrual cycles, say you're a teenager up to, let's say, age 30, where you peak in bone mass. And then there's another phase, I would call it like 30s into perimenopause. Perimenopause being like this phase before menopause where there are some hormone fluctuations. And then menopause and postmenopause are different phases that we're going to kind of look at because, again, girls and women can optimize their bone health in each of those phases, and there's things you can do that are modifiable. So for, tweens and teens, as I like to say, weight-bearing sports participation does increase peak bone mass. And remember, the ideal situation is you're being active in weight-bearing exercises and doing some strength training leading up to that time when you would normally peak in your bone mass. This is a study that looked at 10 different sports and looked at bone density in adolescents and found that soccer players and gymnasts had the highest bone mineral density. Swimming had the lowest. Cycling is another sport that tends to have low bone density just because you're using your lower extremity muscles a lot, but there's just not a lot of load bearing on the skeleton. This is a study of rowers. So a lot of times people think of rowing as not being very load bearing, but it actually does apply a lot of load across, the central skeleton. So this is a study of adolescent rowers that included pre-menarchal and post-menarchal rowers. And rowing did increase muscle mass and increase lumbar spine bone density in these teenage rowing athletes, provided that they were adequately fueled. Because if you look at the athletes that were post-menarchal but not having menstrual cycles and having, suppression of estrogen levels and things like that, they actually did not improve their bone density. So this is an example of a sport that can result in energy deficiency, but when adequately fueled, does actually load the lumbar spine in a way that it can increase bone density and increase strength in adolescence. This is a study done by one of my colleagues, Tammy Scarpella, where they took middle school students, middle school girls, and put them in a 2-year program of resistance training, so strength training as compared to regular gym class that didn't include strength training. And then they followed them for 3 years after completion of the study, and they showed that these middle school girls increased their bone density and maintained it for 3 years after completion of the study. So again, activities that you're doing even as a middle schooler or high schooler are kind of setting you up to a better level of bone density that you arrive at, at age 30, where it can then diminish over time. This was a study of gymnasts, which showed that they build more bone mass early and then carry it forward into adulthood. This is a study where they looked at them 10 years after completion of the sport as compared to controls. And because of all of the impact and load bearing they're doing the sport, they basically built up better bone density in their radius bones and shin bones, and maintained that elevated level of bone density as compared to controls 10 years after completion of the sport. So again, getting to a higher peak mass that you can then, try to maintain or gradually decline from over time is important. So what about athletes who are post-menarchal? So like teenagers, they've already started menstrual cycles, they're more physically mature, they're being active in sport. What could go wrong then? Like let's say they're in these demanding sports and they're doing a lot of weight bearing and strength training and all this stuff. There's something called relative energy deficiency in sport. This reference here that I shared is a consensus statement that really very nicely outlines all of the impacts of energy deficiency on athletes. And it doesn't have to be an eating disorder that is causing the energy deficiency. It could be a mismatch between energy demands and energy intake that is just chronic over time. And what happens is with a chronic, deficiency of energy as compared to output, ultimately this reduces levels of something called follicular stimulating hormone, and female athletes stop having menstrual cycles and essentially stop ovulating and fall into a, depressed estrogen state. And as we'll discuss in other parts of this lecture, estrogen is really critical for maintenance of bone mass and participates in a balance of bone building versus bone breakdown in favor of bone building. So in estrogen deficient states, we tend to lose bone more rapidly. So if this is happening to you, in your high school years or 20s, you are likely not gaining bone and building that peak bone mass that you would like to by age 30. This is a great diagram from that article that just kind of indicates all of these systems that are affected by energy deficiency in sport. And of course, we're focusing here on impaired bone health a bit, but you also will see difficulty with maintaining and building muscle, sleep disturbances, mental health implications, reduced immunity. All these things can be impacted by an energy deficiency. And again, we're focusing on this little corner right here, but it is a much, broader condition. So the treatment for relative energy deficiency in sport is to ideally correct the energy imbalance. This could involve, working with a nutritionist to optimize nutrition, some training adjustments, maybe temporary or, adjustable over time. If someone has presented with a bone stress reaction or stress fracture, obviously there's some recovery from that, and then gradual upgrading of the load that's being put on that bone. Hormone therapy, isn't actually the main treatment for this. Years ago, I think women just used to be put on birth control pills with estrogen if they weren't creating enough estrogen. But like really, you want to get to the root cause before you use hormone therapy as the treatment. And then sleep hygiene to allow recovery. When we sleep, that's when growth hormone peaks. That also contributes to bone health. So it's important if someone is recovering from energy deficiency syndrome to also have adequate sleep hygiene. So I mentioned earlier in, again, talking about relative energy deficiency in sport, the importance of estrogen and bone health in women. This is something that plays out significantly later on in life as well. This diagram comes from an article that I really like that kind of talks about all the different aspects of the musculoskeletal system, the estrogen effects, including cartilage health, so joint health. As women get older, women are more prone to developing arthritis in their joints. That's probably somewhat hormonally mediated because estrogen is an anti-inflammatory hormone. They regulate bone growth and remodeling, and estrogen inhibits bone resorption by cells called osteoclasts. Estrogen affects the lining of the joints called synovium, and impacts inflammatory proteins in the lining of joints. Likely has some impact on maintaining muscle mass and can affect ligamentous laxity, but we're going to focus on the bone aspect of this primarily today. So in perimenopausal and postmenopausal athletes, I think athletes say, mid 30s and upward, dropping or sometimes inconsistent estrogen levels in the perimenopausal athlete can affect bone health. But specifically in the postmenopausal athlete, there's a more rapid decline of bone mineral density, as we talked about, in the absence of estrogen. And if you have someone who, say, is a master's athlete or something, and they're putting a lot of stress on their musculoskeletal system and body, they may be more prone to developing stress fractures or fragility fractures with a fall, for instance, if they're not taking hormone replacing therapy. Um, the data on decreased ability to maintain and grow muscle, we call that sarcopenia, is a little bit mixed. Men and women both lose lean muscle mass as they age, but there's some evidence that in declining estrogen state that it may be a little bit more difficult to maintain and grow muscle. And then again, the inflammation can contribute to menopause arthritis and also risk of frozen shoulder. But again, we're going to focus on the bone mineral aspect of this and bone health. So just, because we're talking about premenopause, perimenopause, and menopause, what is menopause? Technically, menopause is the date, exactly 1 year after your last menstrual cycle. And then from that point onward, you're, postmenopausal forever, basically. And this typically occurs between the age of 45 and 55, with the average age in the United States being about 52. But perimenopause, which is a phase where there are fluctuating levels of estrogen and progesterone, can occur kind of a decade prior to menopause. So that could be as early as age 35. And while everyone thinks of symptoms of menopause as largely being hot flashes and night sweats and things like that, maybe some weight gain and irritability, if you look to the right in this kind of postmenopausal area, some of the most prolonged effects of menopause and estrogen withdrawal are really musculoskeletal. Most people don't have vasomotor symptoms forever, although some people do, but what people can experience forever over time is this accelerated decline of bone density and that increased risk of fractures in women as they age, which ultimately can affect their health span quite a bit. So this paper I co-authored with one of my colleagues from the forum, Women in Sports Medicine, Dr. Wright, and this is called the Musculoskeletal Syndrome of Menopause. And in this paper, we kind of try to summarize kind of all of the impacts of menopause and estrogen withdrawal on the musculoskeletal system, including inflammation, um, decreased muscle mass, osteoporosis, and arthritis that can develop. And, a lot of the pathways that lead to difficulty maintaining muscle mass, arthritis, and bone breakdown all are mediated by inflammation. And estrogen is an anti-inflammatory hormone that ultimately dampens some of the inflammatory responses in our cells that are kind of transmitted through something called pro-inflammatory cytokines. So, why do I care so much about muscle mass if we're talking about bone health today? It turns out maintaining lean muscle mass, helps you maintain your bone density. I'll show some studies later about strength training and the impact on bone density, but our muscles and bones are very tightly related. Even there are hormones produced by our bone cells, like osteocalcin, for instance, which messages our muscles and helps our muscle cells utilize glucose more efficiently. And we use our muscles, and then that strengthens our bones. So, these are very tightly related. Um, we know that estrogen can help maintain muscle cells called satellite cells, and then it also affects basically mitochondrial function within our muscle cells and can contribute to muscle endurance. So female athletes or women in general in postmenopause may have some more difficulty with exercise endurance. But this study really ties these things together and showed that body composition, specifically looking at lean muscle mass, is essential to maintaining bone mineral density. And lower lean muscle mass is associated with worse bone density and more loss of bone density over time in menopausal women. So what does estrogen do to our bones? It stimulates apoptosis of or death of osteoclasts, which are the cells that break down bone, and also inhibits formation of these cells that break down bone. It inhibits the death of the cells that build bone called osteoblasts. So at an average age of 52, if there's a sharp decline in estrogen level, we're now tipping that bone formation breakdown towards breakdown, and we start to lose the bone density more quickly. And depending on the statistic you read, 1 in 2 or 1 in 3 women over 50 will experience an osteoporosis related fracture. So that is a significant portion of the population that is affected. And, this is just a little diagram from a reference here that I also think is quite helpful that shows all of the different mechanisms through which estrogen acts on bone. And overall, the net effect is to increase bone formation and decrease bone resorption. And you can imagine in the opposite setting, in the withdrawal of estrogen, you're going to have the opposite effect. But it works on something called sclerostin. They're actually medications, a class of medications that, inhibit that. It upregulates something called osteoprotegrin and suppresses something called rank ligand. These are all targets of various porosis medication pathways, and estrogen is very integrated in these. The Women's Health Initiative is a very large study that followed tens of thousands of women with and without hormone therapy and yielded massive amounts of information. It was somewhat flawed in that some of the patients enrolled in the study were started on hormone therapy more than a decade after menopause, which led to some misunderstandings of the data, concerns for breast cancer, heart disease, and things like that that have since been disproven. And the initial kind of pushback from the misinterpreted data from the Women's Health Initiative really brought down the number of women in the United States receiving menopausal hormone therapy or hormone replacement therapy. And currently, only about 4.5% of women in the United States do receive menopausal hormone therapy. I think that number is going up as we're seeing more and more data, with giving us better and better understanding of the health benefits of menopausal hormone therapy for women. But what we did learn from the Women's Health Initiative is that there was massive amounts of fracture risk reduction in women using hormone therapy that included estrogen, with hip fracture reduction risk of about a third and vertebral fracture reduction risk of about 40%. And osteoporosis prevention is an FDA-approved use for hormone therapy. A lot of people don't know that, but that is one of the approved indications for use. And this study also showed benefits for reducing joint pain, but again, that's sort of not what we're focusing on today. This is a meta-analysis that looked at the effect of hormone therapy that included systemic level estradiol, and this study looked at randomized controlled trials. And you can see here included over 33,000 participants with over 2,500 fractures. And use of the hormone therapy reduced risk of hip fractures by almost 30% and reduced risk of vertebral fractures by almost 40%. This is a very powerful tool, especially for women under 60, to use prophylactically to not develop osteoporosis rather than chasing osteoporosis with medications to treat the condition once you have it. Osteoporosis prevention interventions, for adults, we can educate them on preventative measures and management. We can talk about healthy diet, we can talk about smoking cessation. A lot of these things apply to younger patients too. Maintaining adequate vitamin D levels, a level over 30 would be ideal. Safety in terms of if someone already has osteoporosis, guidance by a physical therapist in terms of graduated exposure to strength training and certain precautions to be taken is ideal. There's a lot of evidence-based exercise intervention that really works for people with osteopenia and osteoporosis to actually increase bone density some and reduce risk of fracture. Um, Strength training, I'm going to show you some studies that speak to this. Direct loading of bone with impact is helpful. It's important to include balance work, agility, mobility exercises to help prevent falls. And then aerobic exercise is always important for cardiac health. So what can women do to maintain bone density aside from using menopausal hormone therapy? Um, Strength training primarily benefits the lumbar spine, but also benefits the hip region. Impact training primarily benefits the hip region in terms of increasing bone density. There's some evidence for use of hydrolyzed type 1 collagen. There is evidence that creatine monohydrate supplementation indirectly can improve bone density through increasing lean muscle mass. And then, of course, dietary assessment and interventions may help as well. The most well-known study in terms of strength training and the impact on bone density is called the LIFT-MORE trial, which is a randomized prospective trial of women on average age 65 who were either osteopenic or osteoporotic who participated in an 8-month program where after 2 months they gradually progressed them to a more high-intensity strength training. And they did basically 4 maneuvers: deadlifting, overhead press, back squat, and some jumping chin-ups to create some impact. And this was done twice a week. And the end result was that the women in the intervention group gained 3% bone mineral density at the lumbar spine, also some significant gain in the hip, whereas the control group lost an expected amount of, like 1 to 2% over that time frame. Um, Impact training. This is a study looking at postmenopausal women who are randomized to doing 10 to 50 jumps a few days a week to stimulate bone density through something called mechanotransduction. So there is something that occurs when we jump or impact where there's basically a vibration essentially transmitted through the impact that leads to a biochemical response that stimulates bone formation. And in this study, after 6 months of this intervention, the intervention group gained about 1% bone mineral density at the hip, whereas the control lost about 1%. There is evidence that impact training works better in premenopausal women than postmenopausal women, just more gains from the same type of investment. This study, for instance, looked at premenopausal women, and they showed a 3% increase in hip bone mineral density with jumping 50 times a day over a 5-month period. And so I think there is probably more to gain in that range, but it's also good to include in postmenopausal women. So, if you're in your 30s or 40s, it's a great time to incorporate impact or jumping to create that stimulus for bone density. And if you're someone who's older, and maybe you already have some osteoporosis and you have bad knees or something like that, and you can't jump, there's also some evidence that something called heel drops can create some increased load across your bones as well. Fortibone is a brand of a type of hydrolyzed type 1 collagen, and there was a randomized controlled study done where people stayed on the supplement for 4 years and showed significant increases in lumbar spine and hip bone density. I haven't seen any data on this on actual fracture reduction risk, but there was good DEXA evidence. Creatine monohydrate, I mentioned, does have a secondary effect on bone health. This is really driven through increasing lean muscle mass. Studies do show increased lean muscle mass and strength in menopausal women using the supplement. It's been studied, very safe, but it's not really probably a direct effect. There are also multiple studies showing some potential cognitive effects with creatine monohydrate supplementation. And then diet, important for menopausal women to get calcium of about 1,200 milligrams a day. If you're a teen, more like 1,000 milligrams a day. And this can be through dairy, cruciferous vegetables, kale, bok choy, but not spinach. Spinach has a really poor availability of calcium. That's kind of a misunderstood thing. Vitamin D, 600 units per day is daily value. You can get this from eggs, fatty fish like salmon, mushrooms. It's also okay to just supplement vitamin D. Like a lot of people have a really hard time getting that from their diet, and it is actually supplemented in quite a lot of dairy products. Magnesium, 400 milligrams a day, is important because it helps activate vitamin D, which we use to help absorb calcium. And then vitamin K, we can get in our diet through leafy greens, fermented foods, and eggs. Vitamin K has a function that once we absorb calcium, it kind of can help direct calcium to our bones. So those are some of the ones I like to highlight in the diet. And then, it's also helpful, I think, to think about an anti-inflammatory diet as we age, especially minimizing red meat, saturated fats, processed foods, but including whole grains, lean proteins, healthy fats, um, fruits, vegetables, and we can also include, things that are other antioxidant-rich foods. But there is a connection between inflammation, both to arthritis and osteoporosis, because they're inflammatory signaling pathways that both contribute to breakdown of bone and our cartilage in our joints. Just want to mention, of course, while we're talking about bone health, that cardiovascular disease is a leading killer of women. And so it's really important to also recommend to people, even though we think it's super important to include strength training lifelong, a couple of days a week, that you don't want to neglect cardiovascular exercise because we know that, 150 minutes of moderate intensity aerobic exercise per week helps our heart health and also can help with prevention of dementia, which is also more common in women. Other tips just for, thinking about hip fracture patients. Physical therapy is an invaluable tool for patients after hip fractures. These are people who already have had a fall. They probably already have osteoporosis. They develop something called kinesiophobia, which is fear of movement. And they need help restoring balance and mobility as much as possible. Interestingly, I just wanted to share in here kind of like things that we're learning. There's something called the Step High trial that showed that women who had hip fractures who were treated with testosterone after surgery um, actually had decreased risk, a 50% decreased risk of needing an assistive device versus controls after hip fracture. So we know that people who break their hip often need like a cane if they didn't need anything. If they needed a cane, they then need a walker. If they need a walker, they then needed a wheelchair. So testosterone is another hormone that declines in women gradually as they age. And this study actually showed that supplementing this after hip fracture helped women recover from hip fracture surgery and be less likely to need an assistive device. Lastly, if there are any, uh, medical practitioners treating patients listening here and treating elderly patients, or really any woman that's not even elderly, just women who are menopausal, recurrent UTIs are a problem with estrogen deprivation and frequently contribute to falls in the middle of the night. And UTIs are the number one complication of hip fracture fixation in our orthopedic patients. And there's a wealth of information now showing that local vaginal estrogen reduces the gets rid of recurrent UTIs in many patients, and that can then help with reducing risk of falls and fractures and complications of hip fracture fixation. And then one other little subgroup of women I want to not leave out ever is breast cancer patients, who many of them are treated with aromatase inhibitors, for instance, which essentially put people into like an early medical menopause. And this increases risk of joint pain, frozen shoulder, but also osteoporosis, because women are experiencing that declining bone density at an earlier age than they otherwise would. And also women who have gone through breast cancer treatments, surgeries often have lymphedema, which can be associated with kinesiophobia, fear of movement, and they sometimes reduce their activity level, may not be doing some of these things that also can benefit bone density. So I think just important considerations, not forget if you're treating patients who are kind of at this, intersection of conditions. So in summary, improving bone health and the health span in women involves a tailored therapeutic exercise program and education to reduce risk factors for midlife women, but a lot of that starts in, our teens and tweens and 30s in terms of optimizing our bone health. But if we didn't know about any of that stuff before the age of 30, it's not too late. We can still start somewhere in terms of reducing risk of osteoporosis and addressing joint inflammation and musculoskeletal health. And I didn't talk about this because this lecture is focused on bone health, but also pelvic floor dysfunction in women as they get older. So, speaking to the, earlier things you can do. Screen your young patients for relative energy deficiency in sport. Educate your younger patients or athletes, whoever's listening here, on the benefits of weight-bearing exercise and strength training in sport, but adequate fueling so that we get the benefits of those activities without the negative potential, risk of energy deficiency. And then, it's important to consider healthy lifestyle choices at all ages. So with that, I'll do questions, and I hope I spoke to all.